most of all addiction care, 100%, it's just a higher stakes, is a reactive care model. So the person is only there because they're struggling. And then the only time that you can do anything to really change things for them or catch them before they fall is to have constant communication or the ability to have constant communication or watch signals.
Welcome to episode 4 of the Saving Dose podcast. Thank you so much for spending some time with us for the next 30 minutes. I'm really excited about this continuation of part 2 of the challenges that we are dealing with in the opioid treatment practice space and helping addiction recovery. My name is William Pedranti. I'm one of your co-hosts. I got Kendra Allen in here with us. Kendra, how you doing?
I'm doing great today. Thanks for asking.
Awesome. Our third co-host, Dr. John Su, still traveling. Unfortunately, couldn't be here today. So it's just going to be Kendra and I diving deep into this great topic that we got, ran out of time last time. There's so much good stuff. So very excited to be here. Thank you so much for being with the Saving Dose podcast. Remember, this is about all things addiction recovery. So whether you're a patient or a caregiver or a family member or a nurse or a clinician or a practice group or executive or just somebody that's interested in learning more about addiction recovery and the challenges of addiction recovery. That's what we're all about here, is to be an opportunity, a source of good information about addiction recovery and how we can help people in the addiction recovery space. So again, very excited about this topic today. Going to dive right in because we got a lot to cover in a short period of time. However, before we start, I just want to share a personal story recently of dealing with addiction and just talk about that a little bit and get your thoughts and reactions, Kendra. I think I mentioned on a previous podcast, I've got a good friend's brother that suffered from addiction his whole life. He's in his mid to late 50s now. He got hooked on opioids when he was in his early 20s from a football injury. And he literally is what you see as a typical, like Dr. Su said on a previous call, that addiction is a chronic condition. And he has dealt with addiction his whole life. And recently, about a little over a month ago, he decided he was getting into he's been sober for a bit, but he decided he was getting into some of his bad patterns of behavior. And he proactively decided to check himself into a sober living facility where he stayed a month. And I had the wonderful opportunity when he called, he didn't have transportation home. So I said, I'll come out there and get you with my friends. So we went out there, not too far from where we were, to go pick him up one Saturday morning. And got to pick him up in the morning. And I can just tell you two things about it. Is came out of that addiction, that sober living facility, was feeling so good after being there for a month. So good about what, he went through, the medication he was on, the psychotherapy he was getting, the group meetings. He told a lot of stories about people there and just the relationships he built in just 30 days there, and talking about some of the people and how good it was for him. And he came out of there so enthusiastic about where he was at, and he was looking forward. They'd hooked him up with a therapist. So he was going to continue to meet with a therapist on a periodic basis to continue to work through his recovery every single day. As I asked him, I said, what is it like to deal with addiction recovery? And he said, sometimes it's day to day, sometimes it's minute to minute. But there was so much positivity, but also he got an opportunity to share with me, Kendra, some of the stories of the people that are at that facility. Tough stories.
Tough ones.
Right? Of people and what they were dealing with. A woman who was a grandmother and a husband, kids, grandkids, dealing with alcohol addiction, who came from another state out there. And he said the withdrawals from alcohol addiction, he said, is brutal. And she came in there and she had to go, no alcohol, obviously, going through that withdrawals those first several days were there. He said, you can't believe how brutal that is. And so, it's just the good and the bad of dealing with that and just hearing that stories, but continue to give me inspiration about what we're doing. So I just wanted to share that with you and get your perspective. I know you've been in this space for so long in helping people with addiction recovery. And so, is that typical? I mean, just curious, have you probably been to a ton of these facilities in your career?
Yeah, we had a lot of them for a long time, a partner of mine and myself. And I would say that's highly unusual, number one, for him to have the cognizance to say, I need to go do this. And for such a short stay, I think that's amazing that he has that ability to do that, because so many people don't. And, I wish some of the people in my life that I've loved and lost could have done that. Right. But it's just not. And maybe it's just because he's that far in his recovery. So although he may feel bad that he had to take whatever time out and kind of go recenter himself. And if you think of our daily lives, I mean, how often could we go and do that? It's just so hard, right? So good for him. And I'm so glad that he is able to find that. And yeah, alcohol, we often see more failures with alcohol addiction than we do opiate addiction. It's just so, number one, it's socially acceptable. So it's everywhere. It's everything, it's with dinner. It's every holiday party. It's social in American life and many other, I guess countries, but it's very, very prevalent here. So it's hard. I think that in a lot of ways, alcohol is harder than opiates for people. But it all goes hand in hand, right? There's happy people don't do drugs. So we have to heal ourselves from the pain that we're trying to numb. And if we don't do that, we're never going to get out from underneath it. Now, like your friend's brother, he obviously hurt himself in football, but there's a radical cycle of depression and anxiety that comes from that. And then there's the shame cycle. And then there's the guilt cycle, which leads to more depression, which leads to more anxiety. So it's a snake eating its tail, right? So if you can't forgive yourself and you can't work through those things, I mean, and sometimes even when you do, it crops up. I mean, stress of life is stress of life, right? So, but kudos to him. And I'm so glad there was a place that could fit him in and make it work. One of our bigger problems is that we just don't have enough providers and facilities and payment coverage, honestly. Money is one of the biggest barriers to treatment that there is. And if they can't get insurance coverage for it, a lot of people just do not have the resources to financially step out of life and into treatment.
Yeah, absolutely. Absolutely. No. Well, and I want to dive into that. Thank you for sharing that with us. I want to dive into our topic today, what we talked about, and that is the practice of addiction opioid treatment programs and some of the challenges they're facing. God bless all these people like yourself and Dr. Sue that have spent a lifetime of helping people with addiction recovery. These people are angels to go in this to try to help people in their struggles. But also they have to be business people too, right? There is the economics of just what you're saying of dealing with, managing and running an opioid treatment program and the challenges of that, just like you said, and concerns about Medicaid crunches and things like this. So that's what we're talking about today. I want to dive right in. One of the things that I've heard you talk about in the past is staffing shortages and burnout that's going on at these opioid treatment programs, right? Driven by labor-intensive processes, whether it's, observed dosing, daily monitoring of all these things. Tell me about that. Would you talk about that a little bit? What are you seeing of these challenges with these opioid treatment programs in terms of labor?
God, we could talk about this all day. So in certain, there's just, number one, we know we have a nursing shortage. We've had a nursing shortage forever. Luckily, I think some things have changed in our education community. We have a lot of RN certificate programs now. We have a lot more online school. We have lots of young men and women who are going through nursing programs, and we're starting to see a small shift in that. So that is awesome, and I hope we can continue on that path. So if you are a young person and you are a nurse or trying to be a nurse, the world needs you. Go do it. It's whether it's a stepping stone. There's a practical nurse, which it's not very common anymore, but it's a certificate program. It's like 9 months. We still need you, you know? And if you're trying to do your RN, it's typically a 18-month, 20-month program, and you get an associate degree and you have your nursing license. So we need you. And in some states like Florida, they actually have a state mandated plan to try to end the treatment provider shortage to cover addiction services and mental health services very specifically. And they have budget lines and student loan forgiveness, and they're trying to do everything they can to retain providers in that state, as well as encourage people to move there and be providers. And they've relaxed their telehealth laws, which we've seen a huge relax in that since 2020, so that's helped. But yeah, we have a problem. And the worst part about nursing, I think, is you get into nursing or to be a doctor because you want to help people and you want to heal people. The hardest part is much like, following a baseball team, right? The Cubs will break your heart is what you always hear, right?
Right?
It's
Yeah,
kind of like that,
100%.
right? So when you're first out of nursing school, there's mostly 2 jobs available to you before you can ever go to a hospital or, make decent money anywhere. And that is addiction treatment or nursing home services. That's kind of like your first, where you cut your teeth. And those are the jobs that kind of break your heart because, it's the elderly. So regardless who they were in their former life in a nursing home, these people are frail and they're kind and, they ring their little call bell and Mildred wants her blanket. And then one day Mildred passes away and it's horrible,
Right.
Um, but in addiction treatment, it's actually worse because we see Ben come in every day. Ben's making progress. He's clean. He's sober. He's doing great. He's visiting his kids. His family's talking to him. And then all of a sudden, Ben disappears. And then bad things for Ben, right? And then sometimes you see Ben again. Sometimes you see that Ben has passed away or someone tells you. And that's heartbreaking because it could have been prevented, So I think that care for our staff is some of the most kind things we can do, and it also will keep our staff with us, and it doesn't necessarily have to involve money. I mean, people to have a 2-hour lunch break or to, have a raffle for noticing that Ben was gone, those kind of care type of things for your staff to let them know that they're doing a great job, it is paramount.
Yeah.
Yeah.
Yeah. No, I love that. So it is because it is a challenge. These are, it's tough for this in addiction recovery, for nursing and stuff.
Yeah.
So certainly showing that is so important. How about the type of activities that these clinicians are focused on? Do you see a lot where, they end up performing administrative tasks or sort of lower value tasks than what they were trained for to be a clinician, right? And provide clinical care to a patient. Do you see a lot of that going on in OTPs today?
I think that is, I think if there's $1 for every complaint, that would be it, right? We are constantly hammering our clinicians to finish their notes as they do them. And before software was allowing AI in their software to take the note for them while they're doing the session and summarize it, this was a huge problem. We were behind weeks and weeks and weeks and weeks in notes, and it just feels like you can never catch up. But when you have back-to-back appointments and the person in front of you is really spilling out their heart, it's really hard to say, "Oh, I'm sorry, our time's up." Meanwhile, she's crying on your couch, right? Like, how do you do that? So we have to acknowledge that things are getting better in that space, that clinicians are doing better in the administrative task area, that AI has really changed that dynamic. Not that we want AI to diagnose people, but also it takes those notes for us, and that also helps us not have so many takebacks and inconsistencies during audit. I think that's been amazing. So if your software doesn't have that, 100% check it out. Even if you just do something like ChatGPT healthcare subscription, it'll make a night and day difference in a clinician's life. But also for physicians, it's the same problem. But I think it's worse for practice owners because it's typically a provider practice owner. And so now they have to worry about billing, not just the notes. And they have to worry about staffing, and they have to worry about if she's sick or someone leaves. And then we have a whole caseload that we have to redistribute and we can't find someone in time. What are the telehealth laws? Did their insurance expire? Did their license expire? I mean, there's an endless line of things that we have to look for. But yeah, I think I think things are getting better on that front from an administrative standpoint, but we still have a long way to go in getting paid on time and not having to fight for payment. I've worked in healthcare and mental health, and mental and behavioral health, especially for addiction and inpatient mental health, is some of the hardest claims to get paid. And I don't think a lot of people understand that, because to get paid for a medical claim, it's very objective. You have the flu, there's a diagnostic formula for that. You see the visit and it's clean cut and you get paid. Mental health is more subjective. So you have someone interpreting a feeling and you have someone interpreting life events. And so the clinician is saying it's this level of care and the insurance is saying, well, maybe not because you didn't check this box. And the next thing you know, a person's at a facility and the facility's having to discharge because the insurance company doesn't think they meet criteria. So that person is back out, in the cold. And
Right.
I think that's horrible. You finally get someone to care. And then to
Right.
actually if they don't have someone to fight for it or that knows how to fight for it, or that patient could hurt themselves in a lot of ways.
Yeah.
So,
Absolutely. Absolutely. No, certainly. No, that's one of the challenges. I want to shift a little bit so we on the clinical side, right? The clinical care side. So, in those situations, obviously the practice has got a lot of work on in making sure staff can be focused on those high value clinical care. But talk to me about, in delivering that clinical care, about visibility into patient behavior and adherence and outcomes. Talk to me about some of the challenges today that opioid treatment programs are dealing with, in these outpatient settings, with patient engagement and intelligence and what's going on with patients.
yeah, there's nothing. It's pretty much a black box. So, we see a patient, they come in, we talk to them, they self-report. Most oftentimes, because of that guilt shame cycle that we all have, regardless of what we're doing in our life, sometimes they omit things, sometimes they straight out lie, and sometimes they tell the truth. But I would say the vast majority, fueled by that shame and guilt cycle, often don't self-report 100% accurately. And so as a provider, what happens is the provider can't tell, do they need a bridge dose? Can we tell if this person needs more medication or less medication? It's the same thing for you. If you go to the doctor and you have high blood pressure and you typically forget to take your medication, or you're just not really 100% on board with taking a medication every day, the doctor says, so have you been taking your medication because your blood pressure is a little high? Typically, you're going to say, yeah, or more or less, So we're not any better, right? Like, it doesn't matter the diagnosis, right? So whether it's mental health or medical, as a whole society, I think we are bad at consistently taking medication for whatever reason. I mean, I personally can come up with a ridiculous justification for not taking blood pressure medication on time or daily, right?
Yeah.
So, so I think that in the addiction and mental health world, when you see those providers, you have a whole different level of guilt and shame tied to it, because bad things happen when you don't take those medications. And the second thing we often hear is, it makes me dull. I don't like to take it because it makes me dull. Because typically we have a mental health medication that's trying to address the underlying issues of bipolar or depression or whatever it is. And then we have the addiction resulting from the underlying condition, right? So if the person takes their buprenorphine, for example, to control their cravings, but they're not taking their antidepressant, it's only half as effective as life could be, right? But the biggest reason people don't take besides what I just mentioned, is that we're just bad at taking medication, I think. But they say, well, it makes me feel dull. And I had an interesting conversation with a patient not too long ago. And I said, explain to me what you mean. And they said, well, when I don't take my medication, I just feel sharper and I feel happier and I feel all the highs and all the lows. And I'm like, okay, so every day's not a bungee jump for me, right? Like, I am never way happy all day long or way sad all day long. Like, there's a lot of days where it's just flat for everybody. You just do the day, and there's happy moments and sad moments and stressful moments. But to have that crazy elevation all day long, that's got to be exhausting.
Mm-hmm.
But see, that's their normal,
Right.
And so if that is your normal, and then suddenly that normal's gone, they have no comparison to, so they feel like it's dull. And, we have another patient who was doing great. He was, before he got hooked on prescription pain medication, he was an operating room technician. And he went to work every day, and he got hooked on some pain medication. And from that, he had a shoulder surgery. And from that, he ended up using street drugs. And from that, it ended up going to heroin. And sadly enough, his wife got involved in somehow, and she died. And he just, completely his life just went completely sideways, the guilt from it, right? So he had made pretty much a full recovery. He got his addiction under control, and he was really just trying to heal himself. And he had gotten his operating technician reinstated, and he had started back to, resolving his life and being a dad. And he started breaking into cars. And we're like, what are you doing? And why are you taking change? I mean, you make, $30 an hour. Why are you taking change? And he lived in one of our sober living homes. And he says, well, I just need that. I need that adrenaline rush. Wow. I'm like, but let's find a sport. Like, what are you doing?
Right.
Yeah, but, sadly, life didn't go in his way, and he just couldn't recover, and we ended up losing him. But, those are the things that break your heart, right? Like,
absolutely.
There's no resolution for that person, and it's hard to watch.
I bet. And that it kind of dovetails the next question I want to ask you about too is in your story about relapse. You hear statistics in the industry about how high patient churn is, as they call it, right? Mm-hmm. Loss of patients that are coming into these opioid treatment programs and getting involved with addiction recovery and then just disappear, right? And relapse. Tell me what's driving that. I mean, you gave me some examples. What do you think are some of the biggest problems why we have such high churn in these addiction recovery programs? And what does that mean for these clinics to be able to survive, right? When they're losing so many patients?
Yeah, it's hard. It's hard to stay in business, for sure. First of all, it's a low margin business. So our biggest overhead is personnel, and good personnel isn't cheap, and the rent isn't cheap. And, there's lots of licensing and insurance. Oh my God, the insurance. So I think the biggest financial barrier the biggest patient churn reason actually is financial. That's our number one complaint of when you talk to, hey, Matt, what happened to you? Well, I lost my insurance because I lost my job, and now I have to cash pay, and I can't choose between food and cash pay. Yep. So that's the number one reason. The number two reason is transportation, 100% transportation.
Wow.
So, a lot of these folks have lost their license or do not have the ability to have enough money for transportation, insurance, car insurance, the cost of the car, whatever. Or they only have one car, and someone else has to take it to do whatever. So that's the second biggest reason is transportation. And if you think about it, I don't know if you've ever taken a public bus, but a public bus takes you hours to go anywhere. I mean, especially if it's across town, right? So unless the clinic's within walking distance of you, and you have to take a bus, and you have to make sure typically these are people who have children. I would say 80% of my patients have children, 20 do not. So you have to get kids to school, then you have to get to the clinic, and then you have to get to work, and doing all of that by 9:00 is incredibly hard. Now, a lot of these clinics open up at 4:30, 5:00 in the morning. Some buses don't start running that early, or even if you do that, let's say you go and you're on a 5:00 bus, so that you can get your kids to school by 7. So you get up at 4, you're on the 5 o'clock bus. It's probably an hour ride between stops. You get there at 6, you take your medication for 10 minutes. Now you're on your way home. You're on the hustle to get your kids. And then, then you have to do that. Anybody with kids knows it's a song and dance. And
Yep.
every day.
100%. Yep, every day.
And it doesn't matter how old they are. And then from there, you got to get yourself to work and then not be in trouble for being late. And so trying to do that on the daily, or even if you're trying to do it 3 times a week, even once a week. I mean, how do you maintain that level of energy to even accomplish that? I mean, you have to be so motivated. I just don't, you have to be very, very motivated. And I think that motivation can, wane because you get tired and you get depressed and you lose faith it's going to work or that you can keep it up.
Yeah.
So,
absolutely.
Yeah. So I think if we can solve these problems, then we can solve big problems for patients and clinics,
Yeah. How much in just that churn? So you mentioned cost as a big driver, transportation, getting to the clinic's a big driver.
Mm-hmm.
How much is, a lack of visibility from the practice group from being able to being proactive? I know you've said in the past, today, this practice, it's reactive, not proactive.
Yeah.
How much do you think that matters? Getting somebody to relapse where the practice groups aren't being proactive or don't have the ability to understand when they can be proactive, such that they're reactive. So patients just aren't getting the support they constantly need to be able to stay in a program.
Yeah. Unless we have a peer support counselor assigned to a patient who they can text, like, I'm really struggling, or they have a really great sponsor that they have a really great relationship with, we have no visibility. Like, we have no ability. So if you think of medicine, if you think, of any medicine, really, like primary care is reactive. You only go to the doctor when you're sick. Typically, they try to get you go for a checkup every year, but you probably don't. Most of all addiction care, 100%, it's just a higher stakes, is a reactive care model. So the person is only there because they're struggling. And then the only time that you can do anything to really change things for them or catch them before they fall is to have constant communication or the ability to have constant communication or watch signals. So we don't have that. We don't have any of those tools. So I only know someone relapses when I'm doing a drug test. And it's typically not because they tell me. I mean, like I've mentioned before, poppy seed muffins, it's an epidemic in this country, I swear. It makes everybody fail their drug test, which it's just silly. But,
Love it.
But yeah, if we had an ability to, because we know what the signals are, right? Like, we have tons and tons of evidence that tell us this leads to this, which leads to this, which leads to relapse. So if we could flag those, if we could go out and just monitor for those signals, then we could flag them, and we could flag those signals and reach out potentially before a relapse happens, and have some just-in-time support where we can help catch someone before it's too late. Because the consequences in primary care are that someone has a cold for too long and it turns into pneumonia. Okay, although it's a terrible situation, the chances of that patient surviving that and they're cognizant enough to take care of themselves is actually pretty good. You're probably not going to lose a patient from that unless they're elderly or have some other condition, right? It's high stakes in addiction. It is literally life and death. Literally. Because if this person hasn't used illicit drugs for a certain period of time, and then they go out and use the same amount they used to use, the chance of an overdose is super high. And the chance of death, if no one finds them, is also super high. So we have to change this. We have to move from a reactive model to a proactive care model and pay attention to those signals that evidence tells us we can watch for. We just have to find a methodology to watch for these signals.
Yeah. Gosh, that's powerful, Kendra. So thank you for sharing that. I agree, right? Yeah. That lack of knowing what's going on with your patient all the time Because like my buddy said, I should say my friend's brother, become my friend, so I can call him a buddy, said, sometimes it's day to day, sometimes it's minute to minute. As we were
Yeah.
driving him back from the sober living facility home, he said that sometimes it's minute to minute dealing with my addiction. And so you're right. Without that support system, without the clinician understanding what that person's going through at that particular second moment, right, where they can make an intervention, right? Pick the phone, send a text, do something to talk that person off where they may be headed.
Yeah.
I agree. It's probably part of that reason why there's so high churn, in addition to some of the things you mentioned right? About cost of transportation is just not having enough care, proactive care to help these people when they need it most.
Yeah. And I think that we also fall down in alumni programs too. So many residential treatment programs have alumni care programs to make sure that their patients, once they leave that residential care setting, that they have additional support and they can be connected to a community and still have interaction that can be supportive before they relapse, right? So, talking to Windmill Treatment Program in Texas just like 2 weeks ago, and we were talking about their alumni program and how they're working on improving it and the different things and different signals they're watching for, and they're doing some great work down there. But she was saying, I randomly just noticed we hadn't called this person in a year, and I texted him, "Hey, this is Ashley over here at Windmill, and I'm just seeing how you're doing." And he's like, "Oh my God, I'm so glad that you reached out today. I'm having a terrible day." You know, so sometimes it's just by chance we can catch people, you know, but if they didn't have her and she is so dedicated to making sure her people by her words are okay, right? Like, it's really hard to find those dedicated programs that are really trying to hold on to people and make sure they're okay afterwards. And there's some new technology they're working in alumni programs. Maybe we can get them to come on and talk to us about some of the things they're doing, because that is changing the model, right? Like, but yeah, we really need to embrace follow-up in a whole new way, But the thing is how do you pay for Ashley, right?
Right. Yep.
So unless your profit margin has something built in somewhere, Ashley is barely reimbursable. And even then, you have to have a mechanism to capture it, which most systems don't have. I mean, there are codes for it, right? But most systems leave that on the table and they forget that they can do that.
Yeah. No, that's so important. And I know you've talked about these alumni programs before. We're running short on time for the podcast, but I'd love just maybe doing this, get another session in the future to talk about alumni programs and what these, like the Ashleys of the world and the Windmills and what they're doing, and how I think it'd be a great topic in the future. Bring them on, talk about what they're doing to follow up. And like you said, how do we make the economics work? How do we use technology? What are technologies we can use that may be being developed today? We have so much technology out here today, right? With med tech and AI and digital health and all these things. How can we use technology better, right? To keep people connected constantly every single day. That's so important. So I think that's a great topic for another day. So knowing we're out of time, I'd just like to wrap it up. Just one more question with you, right? Is just maybe sort of a final thoughts, kind of big picture perspective of where this industry is heading from your perspective. Opioid treatment programs with all these challenges they're dealing with, you talked about, right? With challenges with labor and challenge with patient churn and the economics and reimbursement and travel and geography and all these other things. Staying connected to patients. How do we stay connected to patients and engaged? What's your sort of final thoughts on OTPs, where it's headed, advice to OTPs, what they should be embracing going forward in the future to be successful in providing addiction recovery?
Yeah, that's a loaded question, right? And now a whole nother hour. but here's the short version, right?
We just got a couple minutes.
Right. So the short version is this. Like, I think a lot of our colleagues within the industry, when we talk to them at conferences or whatever, are trying to embrace new technologies as fast as they can find it. This isn't an unknown problem, right? They are trying to hug into anything they can that will improve their patient outcomes. It's important to every provider I know. And a lot of our providers have struggled with addiction themselves, and some of them are even doctors, right? Like, so it's their hearts in it and their souls in it, and they really want to help people get through the valley, right? So I think people are embracing the technology, and I don't think that addiction treatment's going to shrink. I think it's going to grow. We have anytime that we start to have these financial problems, as these big roller coasters, we see lots of people have more addiction problems, right? So I think we'll see addiction censuses increase, sadly. Even if we say the opiate epidemic is we're working on it, and that's all true, but we still have alcohol, and we still have an opiate problem. We still have a fentanyl problem, and we have stuff that creeps up all the time. We have designer drugs that are still huge problems. We have outbreaks of them. Like in Seattle, they have one that animal tranquilizers that they're taking that actually put them in the emergency room, and they have necrotic properties to them. So terrible stuff, right? Desperate people doing desperate things is what it is. Yeah. So we're here to help the desperate. We're here to help heal. We're here to work with patients and help them and their families. And I think everybody in the industry feels that way, or they wouldn't be doing this job, because it's certainly not easy, and it's certainly not getting people rich. It's just we're just trying to work through the roller coaster of problems.
Yep, absolutely. No, thank you. Thank you for everything you've done, Kendra, in your career for this addiction. It's an honor for me to be a part of this with you in this journey to try to help people with addiction recovery. So thank you so much. We're out of time, but I love this topic. I think it's so important is we've obviously focused with Dr. Sue in the past about patients and the struggles that they've got, but this business side of it, plays such an important role. And so I love the fact that we got to spend 2 episodes really talking deep about practices and what they're struggling with and how they continue to provide great care for people dealing with addiction recovery. So you're a tremendous wealth of knowledge. Thank you so much.
Yeah.
Thank you all so much, wherever you are. Our listeners today, thank you so much for taking your time on whatever platform you're listening on. Please follow us, subscribe us, like for us. We've got a website set up you can go to reach out to us. You can reach out to us. Kendra is an unbelievable wealth of knowledge. If you're in the OTP space, you're struggling as a business, and you want some ideas and thoughts and ways that you can help improve your business, please reach out to us through our podcast and our website. We're happy to connect with you to learn more. So very excited. Thank you so much. I'm Will Pedranti. This is Kendra Allen. Thank you so much for joining us today.
Good night, everybody.
On The Saving Dose.